Okay. All right, so like Chantry said, I think most of you know, but I'm Sheena Sayres. I am the director of all of the state opioid response grants here in behavioral medicine and psychiatry at WVU. So we're just going to chat a little about the Healthy Minds mobile unit that we currently have. I want it to be an open discussion as much as possible, so feel free, like Chantry said, um, interrupt me in the middle of anything, send in chats, but I may or may not miss the chat, so Chantry will chime in if so. So we'll just get started. So funding for this for the actual mobile unit is through the state opioid response grants that are passed from SAMHSA down through the state. So anything I say is not actually their beliefs, but that's how it's funded. So this is the mobile unit. I was excited about that little drive-in. Um, so our main mission for the mobile unit is working to expand substance use disorder treatment to very underserved populations in rural settings. So we provide community resources, connections for patients to other healthcare needs, harm reduction, including naloxone and fentanyl distribution, test strips distribution. Um, we have a peer recovery support specialist on staff. We're currently going to Hazel's House of Hope here in Monongalia County with expectations to um, expand to Marion, Taylor, and Preston counties. So, what kind of is the mobile unit? So, we provide substance use disorder treatment on the unit. We do the COAT group-based model. So, we do medication management and group therapy right on the unit. We do have a lab on site for venipunctures, urine drug screens. So, we have a full bathroom. And we can do basic vitals, basic wound care, and then linking patients to other resources. We have lots of patients needing primary care appointments, other psychiatry appointments that we can't do on the unit, but we can facilitate getting them an appointment. Um, so we are currently going to Hazel's House of Hope. We go on Tuesday and Thursdays from 10 a.m. to 4 p.m. We do patient intakes on Tuesday and Thursdays, currently just Thursdays, but we'll expand to Tuesdays again in the near future. So we do coat on Thursday afternoons. So we have a group therapy, then we have group medication management, and then a second group therapy for if people need to do one or the other. So at Hazel's House of Hope, so several of you probably aren't familiar with it since you're not from Monongalia County, but so it's a lot of social services under one roof. So there's the homeless shelter, the Grace Shelter, Lauren's Wish, which is the addiction triage center, Aspire, which is a sober living, United Way, Salvation Army, Catholic Charities. There's a food pantry. Salvation Army also provides two warm meals a day, so anyone can come eat there. They don't have to just be in the homeless shelter or Lauren's Wish. So doing a couple of patient walkthroughs just to kind of give you guys an idea of what happens. So if we have a brand new patient that comes on the unit, we get them registered through Epic or EMR. We'll do urine drug screen, basic labs. Then we'll do a clinical care assessment and a prescriber intake. So, kind of the clinical care assessment kind of answers a lot of the questions, the H&P questions that a prescriber would have. So, we do those kind of together so the patient isn't asked the same questions a million times. And then they'll start COAT if the prescriber thinks that they're okay for the COAT group that is on our site. Sometimes we have to refer out or do inpatient if they need a higher level of care. If we have an established patient, they come in, do a check-in. Well, they fill out a check-in sheet for us. So this is before they know if they're going to have to do a urine drug screen. So they fill out the form. It's basic questions. How many days sober do you have? If you used a substance, what substances? Did you attend any peer recovery meetings? And they sign it. And then we say, you were selected for your drug screen today, you weren't, but it's also then to try to keep them honest and accountable so we know kind of where they're at. And then they'll do actual code. One thing with our patient population, which is very difficult, is to get them to be on time. I know that is a problem with patients in general with our population, but when they are homeless, they don't, a lot of them are homeless and don't actually stay in the homeless shelter. So they're out in tents or other places. And so there's always a million reasons why they're late or didn't know what time or what day it was. So it is hard to just say we're doing coat only at this time, but they do have to be. So our prescriber currently only sees the med management group from 2 to 2:30. So if they're not there by 2, the prescriber can't see them. They can do the later group for group therapy, but not for medication management, which I kind of already talked about some of these, but some of our challenges. So showing up on time. For instance, one time, a patient told us, I don't wake up until my tent gets hot. Well, that's 2 o'clock and sometimes that's 5 o'clock. So they don't really have that like time. Um, they don't have clocks, they don't have phones, so it's just a hard population. So sometimes they come on and say they can't give a urine drug screen. Uh, Extra barriers like they don't have a phone, the bus was late, they missed the bus, all of those types of things. So we also have like challenges with just needing additional psychiatric services on the unit. So most of our patient population needs other psychiatric care that we can't provide in a small setting. So we do have to refer them out. We schedule people for psychiatric appointments or for primary care appointments, and they no show, and they no show, and to the point where we can't actually get them scheduled again with that clinic. We do have the ability that we are down the road from where Valley is, so we do have the option to tell them that they can go there for walk-in appointments. So a few basic numbers. So we actually started taking the mobile unit out on April 30th of 2025. First probably month-ish was slow, like just getting out there, getting to know people, letting them know. Like the very first time we pulled up out there, they thought that we were the police and they all ran. So it just took that like getting to really build that um, connection. And so they realized that they could actually come and ask for help. So our total appointments, which include like an intake, a med group, a lab, um, since April have been 753. We've had a 67% complete rate, 20% no-show, and 12% canceled. We have had a few patients, probably a handful, that we've done re-intakes on, but unduplicated intakes, we've done 36. And we currently have 7 up to 9 active patients currently. So we do have a lot of non-substance use disorder patients that come into the clinic. We have a wide variety of things that they request as far as just like, what are we here for? Some they need like help with their legs or their feet, or when it was freezing out, they just wanted to come into a warm place. We have people just wanting like their blood sugar, their blood pressure, things like that checked. Um, we had someone ask if we could buy them a propane heater. So it just is all over the place as far as whether their medical needs or just kind of social determinants of health, or some people just come in just to chat, like, and it's just that they have somebody there that they can talk about anything to, and they just feel comfortable and welcome in our environment. So, some other common requests that we do get on the unit, we get a lot of primary care appointment requests, discussing other like social determinants of health, like sober living, HUD, employment, IDs, just community resources in general, AA, NA meetings, nicotine replacement therapy and how they can do that. Um, Obviously providing Narcan, fentanyl test strips. So those are some of the like common requests, but then we have those other requests out there that are definitely different. So we do have to have a clinical care coordinator registration, specialists on staff, a PRSS, nurse, prescriber, and counselor. So those are some of the people listed that are out on our unit. We are out there every Tuesday, Thursday. So um, feel free to come visit sometime if you want. A few pictures just to kind of give you guys an idea. So I don't know if I actually mentioned, but it's a 40-foot RV. Um, so lots of things that we've learned about an RV that we never thought we would need to know. So as far as all the maintenance, and it's actually a clinic on wheels, so we have to go through OFLAC. The fire marshal was just there 2 weeks ago. We have to make sure that all of our regulatory like checklists are up to date. We have like med fridges and regular fridges and um, an AED and fire extinguishers and all of those different things that you wouldn't think about in an RV, but they're there. So, also the fun tasks of emptying the tanks and filling the tanks and learning that process. That's a whole different ball game than I never thought I would be doing for work. So this is the inside of the unit. When you first walk in, the picture on the left is kind of like one of our little benches that you can sit on during registration. There's one across the hall as well with a registration desk. That's where they normally sit when they come in to check in or for their first intake or when we're just chatting. The picture on the right, you turn to the right when you actually walk in the unit. Um, and we actually have a pop out, so it slides out, and we have a group room up there. So it holds comfortably 7, 8 is very tight. Um, but also currently our prescriber, Billy Vance, does the medication management portion virtually. So she joins, and there's a TV and camera and all of that up front as well. So um, one less person in there at times. Uh, So this, if you look to the left after you walk in, that first picture is kind of our lab area. We have a centrifuge, all of the things. To the right there, that door is our bathroom. Sorry, I don't have a picture of the actual bathroom. Um, and then further on back is the full exam room. Uh, there's also a door. I don't know if you can see right at the end of the exam room. We have a wheelchair lift. We have actually used it several times, not for patients in wheelchairs, but ones that struggle just walking up and down steps. We can bring them in that way. So, just gonna go over a quick case that we've seen. We could talk about cases all day, but um, we've had a patient that was in our regular brick and mortar coat, all kinds of outpatient settings with us. They failed most aspects of treatment. Uh, Transportation was a barrier, technology was a barrier, not showing up for urine drug screens or actually providing them. Um, they went through all the higher levels of care except for inpatient. So, um, and they just really struggled to succeed in any way. They started coming out to the mobile unit. Not sure how they found out about it, but they came on their own, able to attend actual weekly for Coat Group, but also anytime we ask them to come, they still struggle with sobriety, but they've been able to actually stay engaged in treatment and we're able to really build those relationships up from the time that they first started coming till now is like a huge change. Just seeing that, and they are able to show up for urine drug screens, things like that. They don't have to rely specifically on transportation to the actual brick and mortar facility. They used to be terrified of actually going into clinics. So I think that that was also a barrier for them. And because it's something that we brought to them and it's not attached to an actual building, they seem to think that they're more comfortable. And so it's really interesting to see how taking the treatment to somebody versus making them come to you just makes a huge difference in their care. So we have done a few community events when we collaborated with the WVU Positive Health Clinic. They came out to do rapid HIV testing. So they actually ran the test, did it under their CLIA waiver. You have to add HIV testing to your CLIA waiver if you're going to do that. So they ran it under their CLIA waiver, completed the test, gave the results to participants. Another goal of ours is to try work towards being trained and adding that to our list of services that we do offer. So we did 3 testing events with them. 82 individuals were tested. 3 were known positives, and 1 was a false positive that they run a second test on that was validated to be negative.
Sheena, can I ask, have you guys done any, or is there any plan to do Hep C testing?
We have talked about it, but we haven't gotten that far. But I think that that would be something that we would really be interested in doing. This is just kind of our flyer that we developed, just showing that we're out there. During the summer months, we're usually out there a little longer. Winter, mm, we push it to 4 o'clock. So we also keep our unit in an indoor garage during the winter months. So it is a heated facility that we're able to still take it out because if we were kept it outdoors, we'd have to winterize it. So it's kept indoors, so we don't have to worry about things freezing. And so there was only 4, maybe 5 days this entire winter that we did not take the unit out. I feel like that was quick. Any questions, things you want to? I feel like it's a new, up and coming thing. So anytime you have questions or things you want to chat about or brainstorm, we're more than happy to do that at any time.